Good morning, everyone. I am Sarah, and I'm the social worker at Voices. And I am here to introduce our next panel, which is called Research to Practice the Treatment of PTSD and Anxiety. Today, we have Dr. Joanne DeFede, Dr. Benjamin Suarez-Jimenez, and Dr. Rebecca Rosen. Dr. DeFede is the director of the Program for Anxiety and Traumatic Stress Studies and is an attending psychologist at Weill Cornell. She's a pioneer in the treatment of PTSD using virtual reality and various other modalities. Dr. Suarez-Jimenez holds his doctoral degree in neuroscience and is a postdoctoral research fellow at Columbia. He utilizes various technologies to understand changes in individual experiences when they have PTSD, trauma, or anxiety. And then Dr. Rebecca Rosen is the mental health director at the World Trade Center Health Program Clinical Center of Excellence at Bellvue. And she provides treatment to survivors and oversees the program and also engages in research with other CDC partners. So I'm going to give them each a little bit to talk about their experiences and their research, and then we'll have question and answer time and we'll have a little conversation.
Yeah. All right. So today I want to talk to you a little bit more about what Joanne was talking about, but from the brain's perspective. So with my research, I tried to answer questions about what are the functions of brain areas and how does it come together for mental health disorders. I'll try to do this very briefly. With the invention of MRI and particularly fMRI, we've been able to identify areas in the brain that are of particular use. For example, some areas of the brain are specific to recognizing faces, and damage to these areas can lead you to inabilities to recognize your loved ones. There's areas in the back of the brain that are specific to vision, and damage to these areas can lead to visual impairments. So like I said, this was possible through MRI. So MRI is basically a huge magnet that allows us to take pictures of the inside of your bodies without surgeries or any radioactive materials. So it allows us to study brain structure, size, and volume. Now, the cool thing happened later when we discovered that, like muscles, the brain needs blood to function, and so when you use a particular area of your brain, this brain area gets more blood, and so fMRI picks on that blood flow changes. I'm not going to go into the details, but it creates a picture like this. So it allows us to study where blood is flowing in the brain, and then we kind of assume that those areas are being activated. So with this, we've identified a bunch of areas in the brain that are specific to certain tasks. Like I said, vision, smell, speech, motor movement, etc. Now, we know that not all brain areas are specific, and as you can see here, there's a lot of things that are not even mapped out yet. And this is a very simple diagram. There's a lot more that we know about the brain, but there's even more that we don't know about it. So with that in mind, we've been trying to understand mental health disorders, and so to do this, we look at functional imaging. We also looked at connection between brain areas. This is called the rainbow. So basically, it just tracks down connection between brain areas. But how does the brain changes with experience? How does it changes with age? And how does it work for more complex problems? And then how does it work for mental health disorders? How does it break down? Those are the type of questions that I try to answer with my research. And like Joanne, I use virtual reality, although not as immersive as hers. But I use video games to try to understand this. So I have patients come into our lab, they go into a scanner, and while they're playing a video game, we're recording their brain activity. And so before we go forward, talking about dimensionalities as well, mental health is very multidimensional. There's biological factors, social factors, and psychological factors that affect how a mental disorder may come up to be, but also how it may display itself. And one of the things that I study, particularly in the biology in the brain, is this frontal brain area. It's the prefrontal cortex. So this area is important for things like decision making, planning, understanding other people, inhibiting behaviors. And what scientists have found out is that this area is highly plastic. What that means is that it changes even through going from childhood, adolescent, even through your 20s and 30s. This is one of the bigger areas, particularly for humans. And what happens with the brain when you're developing is that it creates a bunch of connections between brain areas and within those brain areas. And as you develop, as you experience life, traumas, family, you name it, these connections are started to prune. So they are cut away, and this is a good thing because this is how we enhance memories. This is how we create the most important path in the brain. They become more solid, and those that are not used as much, they're just cleaned away so that it creates space for the important ones. So like I said, this is particularly this area is very plastic, it's very malleable, and it's one of the areas that on the brain that continues to develop until your 30s. This is why, as I said, this is important for inhibition control, and this is why sometimes teenagers have so much issues with inhibition control, because this area is still being developed. So aside from this prefrontal cortex area, I looked at other areas like this small one over here called the hippocampus. This area is thought to be, or has been shown to be, very involved in memory and spatial navigation, so finding your way through an environment. And the amygdala, which Joanne talked a little bit about, it's believed to be very important in emotional regulation and emotional output. So with their connections are also very important. And in my research, what we see is that for answering questions that are more complex is how does these areas come together to solve a problem. So I study fear conditioning. So it's how people learn to discriminate between safe and danger. And so what we believe is that the hippocampus assesses the danger and where it is. It's not the same to see a snake in a zoo versus if you see it in front of you. And then you have to assess, am I in danger, am I not in danger? And this is done by the prefrontal cortex. And then the amygdala decides, or the amygdala puts out if we should run or if we should stay. And of course, this is more complicated than that. There's a bunch of other areas. This is the salience network. So it's just a bunch of other areas that come together to assess what is salient or what is important to pay attention to. Is it threatening? Is it not threatening? Do we have to run away? So like I said, with my study, I study these world experiences. And so I have patients play this game. In which they're just exploring a virtual environment. They're picking flowers, which are completely neutral. And we're teaching them that some of them are safe, some of them are not safe. And so as they play this game, we are recording their brain activity, and we're seeing how these brain areas come together when they're learning, once they've learned, when they are in safe areas, when they're in dangerous areas. And then we're trying to use this as well to see why some people lose this ability to discriminate between safety and danger. And why does it, in psychopathology, does it become an exaggerated fear or anxious response? So just to show, this is this is the initial studies that we did with this paradigm, and here we just identified the areas that I talked about at the beginning. Let's see, there was a pointer here. So there's like the prefrontal cortex area, the hippocampus area, and all these other areas that we've identified that are important when people are learning to assess danger or safety, and those who are important for when you are actually in threat. And then we've used this to look at people with anxiety disorders like generalized anxiety disorder and PTSD. And what we can show here is that there's this, while healthy controls uses like this prefrontal cortex area that I talked about at the beginning, other like GAD, generalized anxiety disorders, and even PTSD lack this engagement of this area. And then they engage other areas like the dorsal medial prefrontal cortex, and which is part of the salience network. So basically they feel more in threat even when they're not. So they show this exaggerated response in these brain areas. So with this in mind, we try to think about, like I said, the importance of these areas, their role, but more importantly, how can we use these areas to target treatment, to target diagnosis? Again, as a multidimensional thing, the diagnosis of PTSD or generalized anxiety disorders is used through patients' report. And it's not always accurate. Sometimes they don't even know what they're experiencing. And so we're trying to identify how we can use these areas to not only diagnose better the disorders, understand better the disorders, but also how to treat them. And in a way, we've started to do this, and this is very preliminary findings. It's not as concrete yet, but we are finding that interpersonal therapy and prolonged exposures, for example, so talk therapies can affect the brain differently. For example, interpersonal therapy, which is a little bit more about people's emotions, can change the front part of the hippocampus, and those who go through prolonged exposure can have changes in the back part of the hippocampus. There's some other research that have shown that smaller hippocampus, for example, people who have smaller hippocampus do better in psycho and prolonged exposure and interpersonal treatment. And comparing healthy brains versus those who have PTSD or an anxious disorder, they find that the more normal your brain looks, the better you do in psychotherapy, talk therapy, but the more abnormal your brain looks, then the better you do in medication and other novel type of treatments like brain stimulation, sorry. So we're using all of this to try to understand how these treatments come about. And then, we are developing novel type of treatments like what Joanne has done with the virtual reality. We are testing in our lab equine assisted therapy. And there's a bunch other, like I said, brain stimulation therapies. Now, of course, this is all very new, and I cannot give you concrete answers as to what sort of brain does better for what sort of treatment. But we are hoping to get there. Research is being carried all over the world and here in New York, and we do it as well, where we put people into different type of treatments, different type of MRI experiences, and even modalities of MRI to try to understand these questions. We do this every day. We recruit participants. We have some flyers outside if you're interested in knowing more about that, and also through our websites. But what I want to leave you is with a sense of hope that we are trying. We are learning every day more and more about these disorders, and we are doing everything we can to try to address these questions. Thank you.
And our last panelist before we go into a discussion is Dr. Rebecca Rosen.
And so what do I do here? I just got forward. Okay. So I'm going to shift focus just a little bit. I'm going to talk a little bit about how the research that you've heard about today impacts treatment of the World Trade Center exposed patients as they are in our program, as they present in our program today. So I'm going to talk to you a little bit about our program, its history, the mental health symptoms that we tend to see in the program, and a little bit about our approach to treatment. The World Trade Center Environmental Health Center program offers screening, surveillance, and treatment for World Trade Center related medical and mental health conditions. The Survivor program, as opposed to the First Responder program, serves a self-referred community population. That means that self-referred refers to people have to come in with some symptom. They have something that they're concerned about, and the community includes local workers, local residents, students, passersby, cleanup workers. One of the things that makes our program quite unique is that we have an extraordinarily diverse population. So we've got roughly half men and women. We have people from an incredibly wide range of education levels, income, races, ethnicities, speaking many different languages. The program has 3 locations. Our main location is Bellvue at 1st Avenue and 27th Street in Manhattan, Gouverneur, which is downtown, and also Elmhurst Hospital in Queens. We provide treatment and surveillance for what are referred to as certified conditions. Certification is this official determination of the relatedness of a condition to exposure to the event of 9/11. We call that certification. And once a person's condition is certified, they're entitled to, as I mentioned before, ongoing surveillance, treatment of those conditions, and in our program we also counsel patients on psychosocial needs. Just a little bit about the history of the program. The program started roughly in 2002, unofficially, when Dr. Reibman, the medical director, treated people who came to the Bellvue Asthma Clinic. In 2005, it was funded by the Red Cross, in 2006 by the City of New York, 2008 by federal funding, and then in 2011, money was allocated for the health program by the Zadroga Act, which was then renewed in 2015 for 75 years. Just a little note, the Survivor program would never have been possible without the activism of community organizations such as Beyond Ground Zero Network and 9/11 Environmental Action, as well as others. Something that is also unique about our program, as opposed to a number of other large surveillance and treatment programs of public health disasters, is that from the very beginning, mental health was taken into consideration. So, while at the very beginning people could only come to the program if they had a complaint that was a medical complaint, still screening for mental health symptoms took place. And they found, not surprisingly, there were lots of reported symptoms. So this is just a little example. When looking at symptoms reported by patients who were enrolled between 2005 and 2009, there were very high rates of mental health disorders as assessed by screening tools. Not actual diagnosis, but what people seem to report and met threshold on some screening instruments. So shortly after that time period, indeed, people could come to the program even if they were only reporting mental health. They could report mental health symptoms or medical symptoms or both. And now when a person comes, we use screening instruments to roughly assess for symptoms of conditions that are considered likely to be related to their 9/11 exposure. We also do a short interview to assess for other symptoms, for their mental health history, and current life situation. If a person seems to have symptoms that are likely to be related to 9/11, which seems to be impacting their life in a negative way, and if they would like to be considered for treatment or even for just for certification, we will assess them further. So what are these conditions that are considered likely to be related to their exposure on 9/11? In other words, the conditions that we certify people for. Well, PTSD, which you've heard a lot about today, depression, anxiety, substance use disorders, and these are conditions that are considered to be directly related to 9/11. There are also some conditions, mental health conditions, that are considered to be associated to medical conditions which are related to 9/11. So in other words, depression, anxiety, or what is referred to as adjustment disorders. What does this mean? What are the conditions that you've heard a lot about? Well, PTSD mostly, right? PTSD has, Joanne spoke a little bit about the symptoms of sort of anxiety disorders overall. So you guys have heard a lot about PTSD, but there are 4 symptom groups of PTSD. Number 1 is re-experiencing. That could be nightmares, it can be flashbacks, thoughts that come into your mind that you can't shake and you can't control. Avoidance symptoms, those are doing anything that you can to stay away from any kind of reminders of the event. Thoughts that remind you of it, people that remind you of it, places that remind you of it. Negative alterations in cognitions and mood, that refers to a change in sort of your thoughts and your emotions. Negative thoughts, for example, negative thoughts about yourself, about the world, about your future, about other people. Negative feelings also, depression and anxiety. Dissociation, which is not feeling like you're yourself, not feeling like you're in the world. Anxiety, I mentioned that one. Blame, isolation. Alterations in arousal and reactivity. We often refer to that just briefly as hyperarousal. Being easily startled, being very irritable, having sleep disturbances, hyper-awareness of your surroundings, risky behavior. And then depression and anxiety. Some of the symptoms, some of the hallmark symptoms of depression, being low mood, loss of interest in things that you used to enjoy, problems with sleep, energy, appetite, feelings of guilt, hopelessness, helplessness, and anxiety. There are a bunch of different anxiety disorders, but sort of overall, in the body, anxiety is experienced as unrest, nervousness, tenseness, heart racing, rapid breath, sweating, trembling. In the mind, worry, and sense of doom. So, those are the textbook symptoms. What else? Well, the reality of what people present with when they come to our program 17 years later, the realities are very complex. So here's just an example of some of the complexities to try to understand them. Interpersonal difficulties. One of the things that is unique about this particular event is that it is both an environmental and an interpersonal trauma. And the interpersonal piece can lead to a great deal of distrust in other people, loss of faith in others, loss of faith in relationships, isolation. People have difficulties with numerous areas of their psychosocial existence. Relationships can be considered part of that too, but another example is work. People may engage in an incredible amount of avoidance, which can compromise work, as well as people can have concentration difficulties, attention difficulties. This in turn can lead to significant economic hardship. People experience personality changes as a result of the event, adapting their thinking and their behavior after the attack, which impacts everything in their life. There's also an enormous overlap between medical and mental health issues. And as a program that treats both, we're kind of uniquely set to be able to address this on many different levels. One example of that would be this. Let's say a person has both asthma and anxiety. What may look like at any given time is a breathing difficulty, could in fact be asthma. And the two also can play off of each other. So for example, let's say a person begins to have trouble breathing, and then they become anxious. which then makes their breathing more difficult, and so on and so on. And then there's also, of course, very significant mental health comorbidities. That means having a couple of mental health diagnoses or conditions at one time. So, what are some of the treatments? Speakers you've heard speak about the treatments today, they're on the cutting edge of traumatic studies, and we use their treatments and others who are doing research, and we've found them to be very effective. But while we may have very strong beliefs about what kind of treatment is best for a given patient, a patient is not going to be helped if they refuse treatment or if they don't come back for treatment. And this can be the risk of some kinds of treatments, especially the treatments that make people feel a lot more anxious before they start feeling less anxious. So we work very hard to engage patients where they are and hopefully lead them to the treatment or the integration of treatments that we feel would be best for their specific condition. Treatment response also really varies from patient to patient. So what does this mean? So I'll give you an example. Let's say a patient comes in and we think that the first line for this patient should absolutely be therapy, absolutely talk therapy. But the patient doesn't want to talk. The patient says, no, I'll take a pill, but I'm not talking. So maybe we'll have them meet with a psychiatrist, and perhaps medication is indicated in their case, in which case they can start medication. If it's not, maybe they'll have a couple sessions with that psychiatrist and build trust and build understanding and hopefully be able to understand how their specific situation may be helped by psychotherapy. So that engagement, that trust piece will hopefully be able to lead to effective treatments. So we've heard a lot about some of the extinction-type therapies, which tend to fall under the behavioral or cognitive behavioral type treatments. I'm working on thoughts and behaviors. And you've heard a lot about how it helps patients face their fears, confronting the reminders of their trauma. Anxiety at first rises and then subsides when a person can evaluate it in a safe environment. And then they habituate to it. And then the anxiety hopefully lessens with each exposure. Example of treatments that sort of fall under that category that we tend to use: prolonged exposure, cognitive processing therapy. But again, as I was mentioning, sometimes people refuse to engage in these types of therapies, or they don't come back. And for some people, in fact, these aren't the right treatments. For some people, they never habituate. Not 100% sure why exactly this is. For some people, they won't ever habituate to the anxious stimulus. For others, it just doesn't do anything for them. It keeps them at the same level. But it can help immensely. For those that it helps, it can help immensely, specifically with anxiety and with avoidance. And as I mentioned before, there are also many interpersonal aspects of PTSD. PTSD is not a heterogeneous disorder. Lots of different things make it up. Interpersonal psychotherapy can help with this. It can help with the withdrawal, the mistrust, the avoidance of interpersonal interaction, irritability, interpersonal hypervigilance. And IPT, interpersonal psychotherapy, it can be especially helpful for people who have depressive symptoms along with their PTSD, or a prominent depression presentation to their PTSD. We use some mind-body approaches, such as mindfulness training, to refocus the mind on bodily sensations in the present. We use 3RP, which is Relaxation Response Resiliency Program developed by Herbert Benson. We recently did a pilot study using this treatment with Spanish speakers in our cohort. We translated the treatment for them, and it's a treatment that helps people with chronic stress to elicit the body's natural relaxation response, to understand and cope with anxiety and with stress, and to encourage growth as a person. And our tiny pilot found that there were significant improvements specifically on exercise and stress reduction. We also use medication to treat our cohort, SSRIs are shown to be effective, specifically paroxetine and sertraline, as Joanne had mentioned, although the effect sizes are not huge necessarily in research. There's a medication we find to be very effective for our patients who have nightmares, and we also treat patients with sleep difficulties as well. We also have some group treatments, and I know that in the interest of time, I'm going to skip down to the last bullet point that I have there, which is about stigma of mental illness and stigma of treatment. This is something else that we work very hard to overcome in our population. We have a sort of a drop-in group that is a stress and relaxation group that is for anybody in the program. You don't have to be certified for specifically a mental health disorder. And one of the things that we attempt to do through that group is to normalize what people are experiencing. For some people, it's enough. For some people, this is what they come to our to the group for, and it works for them. For other people, it can be a doorway into treatment to really help them overall change their lives and relieve their symptoms. So that was a little taste of the program as a whole, its history, and the mental health presentations people come with, and how we tend to approach treatment.
So one of the things I think that each of you can speak to is, after all these years, some people are just now coming forward and saying for the first time, I'm having this difficulty, or this is something that's bothering me. And they're not necessarily, they may be showing up to a clinician that doesn't specialize in trauma. They may be coming forward for just some anxiety, life difficulties, things like that. How do you suggest approaching that or encouraging people to seek treatment? Whoever wants to start.
So, I mean, we experience that a lot, and I had mentioned it, I think, in my talk too. We have patients who come in and are coming maybe for a medical symptom that they're having, and in our screening piece of the evaluation, it's sort of coming up that they are also experiencing mental health symptoms, and they, I think, as you had mentioned before, never linked ever in their lives what they were experiencing with their experience 9/11. And again, a lot of it, there's a psychoed piece, sort of illuminating this for people, and that can be extraordinarily helpful. But again, for some people, you have to take baby steps, because not everybody is willing to admit that they have a problem. Not everybody is willing to seek treatment for it. So sometimes it's giving a person for us, giving them access to this stress and relaxation group. It's telling a person they can reach out to us if they want to. We're here. So there are lots of different ways. But yes, it is absolutely true that people are coming forward right now after this many years, not having realized that what they may be experiencing is related to 9/11.
Add to that. I would like to add to that by saying, to underscore that if you do come forward, it is very likely that you will be able to achieve some improvement in your quality of life and your symptoms. I mean, a patient in one of our research studies said, by the time he came to us, he was on disability for his PTSD and substance use. He had been a very high functioning person before. He was divorced, estranged from his children. He got better. His symptoms were greatly improved, but he still had all of the psychosocial problems that had developed, right? So it's not a panacea. But the point is that you can improve 10, 15, 20 years after a trauma, and then go about getting your life back. So this fella happened to text me one night after he saw something about our work somewhere in the news, and he said, I want you to know, I went on, I have a new job, I have a better relationship with my kids, I have a girlfriend. things are really a lot better. And so my final comment there is, if you had, high cholesterol or a cough that persisted for a couple of weeks, you probably would seek medical care. Well, if things aren't right and you had some exposure to the World Trade Center or a myriad of other traumas that people experience, why not just go to someone who's qualified, who has expertise in trauma, and talk with them about it and see if they can help you see a way forward that hadn't been available to you before, just like you would if you had the flu or a cold, and look at it just like that. I think sometimes that the anticipation of getting treatment is actually the worst part for a lot of people. And once you get over that hurdle, things can get a lot easier, and people at programs like the World Trade Center Screening and Treatment Program can meet you where you are.
I'm just going to end up with I agree with what both of them said. I just think I want to reiterate a little bit that it has to do a lot with psychoeducation as well, because as both of them said, not everyone recognizes symptoms or even that they've experienced a trauma. There's been many times in our research that we have people coming as healthy volunteers, and then we give them a very simple checklist, and then they realize that they are really trauma exposed, and some of them really do meet criteria for PTSD. But it also goes hand in hand with the doctors as well, because I've had patients that come to our clinic saying that for many years they were being treated for bipolar or for depression, without realizing that they were actually suffering from PTSD. And this has to do with the fact that a lot of the time these disorders are very complex, and then they manifest in multiple ways. So I think that that education from both the medical and from the patient perspective is very important for this. Definitely. But it is very treatable, and I can think of a patient that we saw this week. He came after 17 years from the 9/11 for treatment, and he's doing a lot better now. So, there's a lot of hope for that.
And each of you mentioned a lot of people do experience trauma differently, and their symptoms differ. And you mentioned that there are different changes in the brain, and people respond differently to treatment. How do you determine when you're seeing patients what will be the best first line? Keeping in mind that they may refuse or may not be open to that, but in general, how do you make those distinctions or educate them about all of the options that are available?
Since you're running the treatment.
And not just 9/11 related.
Yeah. It's a tough question.
Yeah.
And we're hoping, one of the new directions, hopefully, that research is moving is into finding biomarkers, so that we can hopefully know in the future what treatment would work best for what person based on what is in their body. For now, we have to be a little bit more nuanced about it. Again, it depends. Let's say a person has very significant memory difficulties. A cognitive-based treatment might not be the first place to start with that particular person. Again, if a person has a real, let's say specifically PTSD, but that it has a real depressive piece to it, the interpersonal psychotherapy treatment is one that would be a good place to start for them. So it really just depends on, again, what the person, the flavor of what is in front of you. And we have a treatment team, and we discuss all of this in a team, so that people don't feel like they're making decisions about a person's treatment alone. And also, the other thing about treatment is a dialogue. And so you always will be talking to the patient. How is this working for you? What are we, how can we work it so that it might be better? Of course, we as the clinicians are experts to some degree, but it's also that person's the expert on themselves.
Anyone else?
I think that's a pretty good summary.
Yeah.
What we all do.
And I think the last question I will ask is, where do you think the future of all of this is going?
Ideally, in terms of treatment of the psychiatric and behavioral conditions associated with trauma, toward a personalized medicine, right? So we are looking now at genetic factors. A lot of research has been done in other areas of medicine in which personal therapeutics are being developed based on your genetic profile and your medical history. That's where we would like to go for PTSD. I think Ben made some reference to it. And for example, one thing we're looking at now are two different genes, brain-derived neurotrophic factor. And in mouse models, my colleagues have shown that mice with the variant on a certain, Met 66, do not habituate in anxiety paradigms. So perhaps if you're human and you have that variant, exposure therapy won't be the best treatment for you. Perhaps I referred earlier to our results with a medication that enhanced extinction learning. Perhaps it would be fine if you add the medication, or perhaps you shouldn't get it all. And then there's another gene that we're looking at that seems to connote resilience, where mice who have this particular variant in the FOD gene actually habituate more quickly, and they seek novelty more. And perhaps you'll do better in certain kinds of treatment. We don't know yet. Actually, we're just analyzing our results for a study of combat-related PTSD, so I can't talk about it quite yet, but I hope to be able to talk about it soon. And I think we'll be going in that direction with both psychotherapies and with medications. And
I'm just going to add to that a little bit to say that there's global efforts as well, like there's the Enigma PTSD, which just tries to gather a lot of brain information as well as genetic information. And with what we know and what we've gathered from the patient's history, we're trying to use machine learning technologies to build a more complex profile of what patients fall into which category of psychopathology and which ones do better with particular psychotherapy, medication, etc., so that when new patients come in, we can input their history, their genetic information, even some brain information, and hopefully get not only a more accurate diagnosis, but an indication or a pointer to which is the best direction for treatment. Because going a little bit to the past question, a lot of what we do is we talk among ourselves what is the best treatment for this patient, and at the end it's the patient's decision to go with our recommendation or not. We always offer them all the available options, and at the end they select it. But if you go to a doctor for a virus, or like an infection, they tell you what you need. You don't tell them what you need. So we're trying to find better ways to do that, and hopefully in the future we can do that.
The only other thing that I would add to that is there's potentially some promising research being done right now on specifically ketamine for PTSD, and also the cannabinoid receptors is an area that people are very excited about to look at for relief of PTSD.
We have time for one or two questions.
Joe Napoli, Resiliency LLC. Just to add what the panelists are saying about what the future is, and picking up on Dr. Rosen's remark about biomarkers, there is a $40 million, presently funded $40 million project looking for biomarkers that's headed by Dr. Charles Marmar at NYU, and it's multi-centered, and Mount Sinai is involved, a lot of different centers involved, both to be able to diagnose and look at what maybe, as you're saying, Doctor, would be things that would be resilient about people and what wouldn't be resilient about people in terms of before we expose people to various traumas, like what do you do in terms of people who are going into the military, what do you do in terms of people going into law enforcement, first responders, etc., to be protective. I'd like to come back to something Dr. Rosen said. And she said that if a person was anxious about or reluctant to do therapy, talk therapy, that then you want to build a relationship with them first. And I just want to go on record to say we have a bias in our field, and that is talk therapy is better than not talking. And I think I've seen a lot of people that have come to me that have gone through too quickly being expected to talk about trauma and have it being worse for them, rather than to build the relationship first and help them with their lives first. And I'd like the panel to address that.
I can say a little bit about that. I mean, this is why we're coming up with novel treatments. Like you said, talk therapy is not for everyone, and it's true that, for example, with prolonged exposure, before you can get better, you have to get worse. And it sounds harsh, but sometimes it is the case that we see in our clinic that symptoms do get worse as the patient explores things that they haven't allowed themselves to explore because they've been avoiding, because they feel numb, etc. Having said that, we do offer other type of treatments, or there are other type of treatments out there that you don't have to particularly talk about your trauma per se. Interpersonal therapy is an example where you try to go around not necessarily talking directly about your trauma. And I mentioned equine assisted therapy, which is another program that we have started, that we don't talk about the trauma at all or your feelings. It's much more about working with the animal to confront or to see how your reaction to things affect the world outside of you. So, there are other approaches, and at the end, it's like the panelists have said before as well, it's a conversation between the patient and the treatment group.
So I completely agree that not everyone should have a talk therapy, and that it should be a collaborative process. I do want to comment, though, Ben, on your comment that people have to get worse in exposure therapy before they get better. As someone who uses all of the various forms of therapy in our clinical program, I would say that that's true for any treatment, actually. If getting worse means you're going to feel more anxious, you're going to feel pain, and you're suffering more, and that it's going to be conscious, whether it's interpersonal therapy, which I'm also trained in, or exposure therapy, I think it's true for all. And I think, unfortunately, because behaviorism involves actually confronting your trauma, it kind of gets the bad rap among psychotherapies as the one where you're going to get worse first before you get better, as you just said. But I think to some extent, it's anticipated in therapy that if by getting worse you mean you're going to feel anxious or sad or cry or think more about your trauma, it's true for all of them, but it's all in the goal, in the service of getting better, and it's temporary.
So we are going to wrap up on that. Thank you to the three of you. I think that was a great presentation. We have...
Sorry, but
No, it's true.
We have about 15 minutes for a break, so if everyone can be back here at 11:25 for our next presentation. And thank you to our sponsors for hosting.